little section. And then there's some other things we'll talk about anatomically. Pons, primarily a relay center bridge. All the major pathways, motor and sensory, pass through the pons. Pons also is the site of the major pedicles that connect the brainstem to the cerebrum and the cerebellum. So it's again just sort of really an important train station, if you will, important depot for communication. And then we left off talking about the midbrain. The midbrain performs a number of important functions. The midbrain, you're up there around the ventricles again, anatomically very important. But we said that the midbrain also contains the site of the cerebral pedicles. The cerebral pedicles differ a little bit from the cerebellar pedicles in that the cerebral pedicles, again, pedicle just means large connecting mass or large connecting tissue, consist of both gray and white matter. The cerebellar pedicles are chiefly white matter, and we'll talk more about those a little later. Some of this terminology we need to, some of the anatomical terminology we need to talk about. But right now, I'm primarily interested in you learning or associating basic functions with these regions. And we said the midbrain, probably, when you think of the midbrain, you should be thinking about the corpora quadrigemina. These very critical, primal, almost primitive sensory processing regions, primarily for vision, for visual stimuli, and for auditory stimuli. And we mentioned the superior colliculi and the inferior colliculi. We pointed out that these, I hesitate to use the word reflex because that has a very specific definition, but these are almost reflex-like responses to visual and auditory stimuli, and they do not require your conscious awareness of the stimuli. In other words, you usually respond to stimuli that are processed in these regions before you are aware of what those stimuli are. We talked about examples of the bird hitting the windshield, for example, blind sight. We talked about, and in the case of an auditory stimulus, again, there might be the fire alarm might go off, and a thunderbolt or some loud explosion might occur out in the parking lot, and you would instinctively respond before you would actually process what is happening. So that's really what we're talking about here, almost these quasi-reflexive responses. Now, clinically, we also mentioned, just to have you sort of think about things, we indicated that in the case of this auditory pathway, let's say you have a neonatal child who's born without functional cochlea, who's born without a functional pathway, anything that might interfere with that pathway between the brainstem and the sensor, the inner ear. Well, the technology exists now, and it's quite remarkable, and I'm not suggesting these children hear the same way that you would, but to simply bypass all of that and run the wiring, run the stimulus, the microphonic stimulus, back to the brainstem. Maybe at a future point, the technology will be sufficient to run it right to the auditory processing centers in the temporal lobe. Who knows? But that's this anatomy makes that type of therapy possible. Again, with respect to some of the anatomical terminology, we have an illustration we'll look at in just a moment. But the red nuclei are chiefly motor nuclei. These mediate, again, very basic, usually in humans and higher primates, postural. At least that's what we think, because we have a hard time finding exactly what they do. Because in the electrophysiological experiments, it's kind of hard to isolate. The current thinking is the rubrospinal pathways are probably important for just regulating coarse postural movements. We'll talk about the motor signals that enable that motion later. And then we've talked about the substantia nigra. The substantia nigra is going to come up again in just a moment. But make sure you realize now it's part of the brainstem, it's part of the midbrain. So we're going to talk about it in association with something called the basal nuclei or the basal ganglia later. But you should understand that that's a bit of an anatomical fiction, because really this region, which is a region that has a high concentration of dopaminergic neurons, is very important in that nigrostriatal pathway that we talked about before. Does anybody remember the nigrostriatal pathway? Yeah, very important motor pathway. But I just want to make sure you appreciate that this is not in the, it doesn't reside with the rest of the basal nuclei that we'll be talking about later. Even though we use it, we incorporate it into a discussion of that, those circuits. So we're looking at a cross section of the midbrain here. You can see most anteriorly you have these cerebral pedicles out here. This is the substantia nigra, and you can see sort of the reason for its name, the deep dark pigmentation. And that's because, I think we talked a little bit about this earlier, dopamine shares a precursor with some of the neurotransmitters. Anybody remember the precursor for the catecholamines? Tyrosine, and that's also in the melanin synthesis pathway. So that's one reason that the stain is so easy. Again, this is, understand, that if you open this tissue in vivo, it's not going to appear dark. This is simply not, well, that's not true. It actually does appear a little darker, and this appears a little better because of the perfusion of blood vessels. A lot of these terms that we use to describe these tissues are just describe how they look under a microscope. We'll talk more about that. And then here's the red nucleus. That's that very primitive motor pathway we talked about in the midbrain. We'll talk about an important sensory pathway. You know where the dorsal columns are. Well, that sensory pathway associated with the dorsal columns, its complete name is dorsal column medial lemniscus system. Well, here's the medial lemniscus, and this will help you understand why it has that terminology later. The medial lemniscus resides, at least in part, in the midbrain. And then periaqueductal grade, this refers to the fact that this tissue resides around the little canal for the cerebrospinal fluid. That's the aqueduct that we referred to yesterday. And then you can also see the superior colliculus up there, which is that very primitive visual processing center on the posterior side of the midbrain, at least at this level. Some of these other things we won't worry too much about. This is part of the reticular formation that is involved in, thought to be involved in your ability to respond to stimuli. Be aware of your surroundings. It's called something called vigilance. And then I mentioned this, and we can't really address this and deal with all the complexities of this, but I just want you to be aware that you will be dealing quite a bit with brainstem patients, and they do present a bit of a moral quandary because the parents, the loved ones of the brainstem patient is going to see the patient in the bed breathing more or less normally, or just potentially normally, having a heart rate, maybe even responding to some type of stimulus. But usually, let's say, as a consequence of a massive stroke or maybe some sort of trauma, some sort of hypoxia. You have lots of patients that go into that have procedures, cardiac procedures or whatever. They put them on bypass, and the nervous system doesn't survive the bypass because the brain becomes hypoxic. But what often does survive is the brainstem. Now, again, I'm not in your shoes. I don't have the. I've often said I don't have the psychological strength to do what you folks do. But how are you going to tell the parents or whomever that their child or whoever is not really going to come back in the same way? Because the brainstem, once the hypoxia, once the cortex has been lost, it's not coming back. But again, they breathe normally, and there's a heart rate, so it can be a very difficult matter. Of course, that's all this slide is addressing. Of course, every state has its own definition of brain damage.
Is Florida one of those states?
What do you mean, Florida?
In brain.
Well, again, every state has its own definition, and I don't recall. Does anybody know Florida's any with clinical training? Yeah, but I think the criteria differ from state to state, and of course that's something you're going to have to be very familiar with because it has legal repercussions and so on. As to when you can take the person off the artificial whatever device there. I know in my experience, the physician will perform the procedure, and then that's the last to see them. It's always a nurse or PA it notifies the family that the loved one has so many hours, and they base that upon, well, it's going to be your appreciation of what is called physiological compensation and decompensation. You're going to learn the sequence of events so thoroughly that you'll probably have a more sophisticated appreciation and know exactly what to tell them. In many cases, know what to tell the family, how long the patient has, and what to expect, and so on, just based on their experience. But every state has its own little tests, and I don't know what Florida's requirements are. We're looking, of course, here at the underside of the brain, and we're looking at some of the cranial nerves. We're going to have a section in the anatomy that briefly addresses. We don't have a lot of time here to talk about cranial nerves. We'll really address them as they come up in the context. But in an illustration like this, there are some basic structures that I would expect you to be able to identify. So this is just alerting even to the anatomy that you need for the physiology course. So for example, you should be able to identify the olfactory nerves and bulbs there that you see projecting anteriorly. In humans, there's not much. If you have any friends that are mice, you know that they have a snout. Well, I have some human friends that have a snout. But they have a snout, and probably what you don't realize is that their brain extends partway into the snout. Right? That snout includes their brain. Now, what portion of their brain is in that snout? Functionally, would you say? Yeah, it's olfactory. You have a massive olfactory cortex. And with dogs, to a lesser extent, well, dogs really don't have the same anatomy, but much larger olfactory cortex. You can see nature in human development has sort of made trade-offs, and many trade-offs. And so with at least in the classical understanding, with the expansion of the frontal lobes, that came at the expense of the olfactory. But we'll come back to that. I have more to say about the olfactory, just pay attention where it is now. The optic nerve, we've talked about the relationship of the optic nerve to the sphenoid bone, for example, where we're going to talk more about that in the anatomy. But here you can see the optic nerves and the optic chiasm, and there's the pituitary gland. Back in here would be at least a portion of the hypothalamus. Remember, the pituitary gland is connected to the hypothalamus, and here are a couple of hypothalamus projections. These are the mammillary bodies that form that are part of the pathway between hippocampus and some other parts of the brain. So this is important in memory. I won't say memory formation, but certainly communication of memories is probably the best way to approach that. Oftentimes in alcoholism, these become destroyed, something called Korsakoff's disease, and probably for the loss of the ability to remember things. All right, so olfactory bulb, the optic nerve and optic chiasm. You should be familiar, you should be able to identify certainly the trigeminal in this class, the the trigeminal, semilunar, Nasserian. What else is it called? There's like 5 different names. But this is the trigeminal ganglion. And let's see. Be able to, we're going to be talking about the vagus at great length. So note that the vagus emanates, it's the largest of these individual nerves down here in the medulla. So it's prominent. And then inferior to that are the branches and movements of the accessory nerve, the spinal accessory nerve. So be able to identify those. I think for physiology, I'm not going to ask you to denominate all of these and pick them out in various illustrations, but you should be able to recognize the larger structures. All right, so we talked about the brainstem. Let's move on to what rests on top of the brainstem. I guess I changed my slide. I guess they didn't move over. So the thalamus rests right on top of the midbrain. It is part of embryologically what is called the diencephalon. There are a number of diencephalonic structures, including, for example, the subthalamus, the epithalamus, which includes the pineal gland. But most of the diencephalon consists of the thalamus. Now, it's a bilaterally symmetrical thing sitting right there on top of your brainstem, about the size of a couple of walnuts. And it's very complex histologically. And you should know that in the thalamus, bilaterally, there are nuclei. You know the definition of a CNS nucleus now. There are nuclei for each of your senses. There are dedicated, specialized regions of the thalamus for each of your senses, with the exception of smell. And maybe equilibrium. So there's going to be a visual nucleus. There's going to be an auditory nucleus, and so on. You should also know that the thalamus receives input from every other region of the brain. It receives information from the body, receives information from the spinal cord, receives information from the cerebral cortex. In fact, it has every one of those nuclei has extensive connections with the cerebral cortex. These are sometimes called thalamocortical radiations. Thalamocortical radiations. I think in here somewhere. And well, you can see the radiations here. And so these are the radiations, the communication back and forth between the thalamus and the cortex is called thalamocortical chatter. Yes.
Well, so you said thalamocortical. Does that mean it's got efferent?
Yeah, exactly. Yeah, and you can see if you look at these arrows, it's efferent and afferent. So it's back and forth. Each one of these nuclei is radiating. For example, I'm sure you would anticipate that the lateral geniculate nucleus, which is the visual nucleus in the thalamus, is primarily talking to the occipital cortex. And so what you have is this sort of sensory-specific chatter. And so what is it doing? Well, the first thing functionally you should keep in mind about the thalamus, it's processing all the sensory information coming in and helping to integrate that. And just think about it tonight, all the way that you're able to process information, let's say compared to a computer. Imagine writing a computer program that would do just even a minuscule portion of what you can do with the sensory data coming in. Well, the thalamus properly is the first sensory filter. It's filtering the sensory information. There is a fire alarm over there, but you're not really conscious of it. You're not really aware of it. You're not really aware of the noise out in the hallway unless I direct your attention to it. Now, there are a number of circuits in your brain that enable you to focus and select information from the environment as to what's important and what's not. But the thalamus is sort of the first filter, the first processor of all this information. Your thalamus is telling you right now, well, what's more important? Is it my tactile information, the feedback from my fingers while I'm typing, or is it, again, what I'm smelling? Are you even aware of what you're, probably I shouldn't ask that question. Are you aware of what the odors in the classroom right now? Even if you are, it's probably not the issue of priority because you have more important things to attend to. So again, the thalamus is very, very critical in this filtration process. Yeah.
You said there was no smell?
What?
I thought you said that in the...
I know, thank you. Yes, you're the superior logician. Thank you for that clarification. All right, so with the smell goes, we just saw why. Why do we not include smell in the thalamic circuit? We just saw in the anatomy a moment ago. Where does your smeller go? It goes right smack dab to your brain directly. Okay? We'll talk more about that in a moment. That's the limit. Thank you for that clarification. I cannot express my gratitude sufficiently. So be familiar with this thalamocortical concept. The radiations refer to the anatomical pathways. The chatter refers to this efferent and afferent communication.
Well, there's efferent and afferent communication with the cortex. When we talk about the spine, is it also both efferent
Not
and
so
afferent
much.
down the cortex? Only one way.
Yeah, good question. Because really the thalamus is gathering information from all the senses. But the chatter, and it's very critical for the thalamus to function properly, has to be bidirectional in the cortex. Now, if you have a patient who has lost thalamic function, boy, there's just a wide range of possibilities. The most common symptom is, and I can't tell you why actually, profound unilateral pain or numbness. And don't know why that is. If the entire thalamus, because we're talking about, sort of a focal stroke or some other type of mechanical damage. If for whatever reason, following, there's a condition in which the blood vessels to the thalamus are lost, oftentimes patient just shuts down. They just sort of lose contact with the environment, with the world, and almost similar to a basal nuclei disorder. So you get some idea that some patients they report just numbness, and in other cases it's pain, but oftentimes it's associated with loss of thalamic function. The other thing, let me just stress once again, be aware of these nuclei. There are nuclei in the thalamus for each of the senses, with the exception of the olfactory sense, and arguably maybe the sense of balance.
Professor?
Yes.
You were saying that it sends motor neurons out to the brain once it's filtered the sensory. Does it also send motor neurons down the spine?
No, that's what the others were
That's what-
asking.
okay.
That's what Bob was asking, I think. So the thalamocortical chatter bidirectional was chiefly between the thalamus and the cortex. The signals coming from the spinal cord are chiefly afferent. However, I should say, and we don't know a lot about this, there are extensive interconnections between, for example, the cerebellum and the thalamus. And you might find that interesting to read up about those. A lot of what we're going to talk about today, the understanding is fairly vague. So the thalamus is your initial sensory processor. Let's talk a little bit about the hypothalamus. Pretty much you can get along with about every part of your brain except for the hypothalamus. It's really the only part of your brain that's absolutely essential. And by that I mean, just look at the list of things here. That your tiny little hypothalamus, which is just anterior and inferior to the thalamus, is responsible for. It's a very important component of the homeostatic regulation, both the endocrine system and the autonomic nervous system. Remember, it's one of these control centers that is sending signals, in some cases, directly to autonomic effectors, in other cases, to the brainstem. It plays a role, for example, as you look at some of the functions down here in your sleep-wake cycle. The diencephalon includes both, for example, arguably, depending on what anatomist you talk to, both the hypothalamus and the pineal gland, sometimes part of what's called the habenula. And this pineal gland are little light, be careful. They're photosensitive cells that have lost the ability to sense light. So in human brains, unlike a reptilian brain, these cells are kind of like rods and cones in the eye, but they no longer respond to light. What they do respond to are visual signals coming in the morning, your pattern of behavior throughout the day, your activity cycle. And it's very important, the habenula in that region is very important in regulating circadian rhythms, daily rhythms. And a lot of things can go wrong if that circadian accountability is compromised in some way, such as sleep cycles. And we talked about the importance of sleep. By the way, before we leave it, let me point out again that the hypothalamus regulates it. The pituitary gland gets all the hype, but it's really the hypothalamus that is the master gland of the endocrine system. The hypothalamus basically bosses the pituitary gland around, tells it what to do. We're going to find out that the hypothalamus, in addition to being part of this diencephalon, is also part of something called the limbic system, a sort of an artifice contrived by a neuroscientist back in the 1980s. He took a lot of grief for it, but it's a term we still use. But it's a region that, I tell you that instead of the second hour of class day, we're going to have a test. And I can see the red face, and I can see the anger boiling over in all of you. All right. In order for your face to turn red, what must happen? Yeah, there has to be some type of palpable physiological response involving change, redirection of blood flow. And remember that's a somatic response, but what triggered it, what originated it? Some higher brain process. All right. So the limbic system is sort of the link between the higher brain systems and the primal physiological responses. And we'll talk more about that in just a moment. But in any case, the hypothalamus is involved in all that. The hypothalamus is involved in anger, fear, and reward processes. It's sort of the the penultimate effector of those responses. Hypothalamus is also important in regulation, along with some other portions of the brain and other systems, regulation of appetite, satiety, or sense of fullness, reward, water balance, when you feel thirsty, when you don't. Right? Thank your hypothalamus for your ability to differentiate that. Critical for thermoregulation. As you can see, I clearly have hypothalamic issues because I'm always cold. I'm joking, of course. There could be many other things wrong with me. I'm not responsible for them. We talked about the mammillary bodies, which I've misspelled here, involving the ability to respond to, in association with the limbic function, odors and tastes, and so on. So hypothalamus is absolutely critical. Again, we're going to mainly focus upon these functions up here, its ability, its contribution, I should say, to homeostasis through autonomic regulation of blood flow and regulation of the endocrine system. All right, so we've talked about the brainstem, we've talked about the thalamus that lies on top of the brainstem, we've talked about the criticality of the hypothalamus and associated structures that lie just anterior to the thalamus. Let's go the other direction. Let's move back to the this region back here, the posterior to the brainstem, region called the cerebellum. Literally means little brain. Phylogenetic development, quite interesting. And there are all kinds of books written on the cerebellum. There's a fascinating new book that just released in the past couple of weeks which argues that the cerebellum is a seat of creativity, that you would have no creativity without your cerebellum. And his argument isn't very compelling, but at least I submit it for your consideration. What we do know, and what you should as a PA know about the cerebellum, is that it is essential for normal motor function. As our discussion of neuroscience continues, we're going to talk about the regions of the brain that is most important for motor function. There are three of them, and we can mention them now. We'll talk about them more. The cerebellum is the first we'll talk about. Mostly important for your ability to precisely regulate the movements of your hands and the tongue and so on. Let's just say motor precision. Something that driving a Plymouth I'm very accustomed to. Another portion of the motor function would be the basal nuclei. We're going to talk about the basal nuclei in just a moment. Basal nuclei include, for example, the substantia nigra we've been talking about. And then the third, where the rubber actually meets the road, to continue my Plymouth analogy, is the motor cortex right up in here, your anterior motor cortex, because that's the region of the brain that's actually responsible for sending the signal down to your skeletal muscle. And we'll talk more about those motor facts. So three regions that we will argue are most important for motor function: the cerebellum, the basal nuclei, and the motor cortex. All right. So we said the cerebellum is most critical for refinement of motor function. We sometimes call it the analytical comparator. Some of you are typing, some of you are writing, some of you are pointing and doing other things with your fingers. It's your ability to make those very precise movements require an intention, require a very rapid formulation of what you want to do. You then begin the process of doing that, and then through a series of feedback circuits, the cerebellum is constantly comparing in real time what you intend to do with what you are actually doing. And it's correcting on the fly. So we call it the analytical comparator. It's comparing intended motion with actual motion and ensuring that the two are more or less equivalent. If you want to test your cerebellar function right now, this only applies to the first time, because once you do something more than once, other circuits are involved. But if one of the tests that I'm not a clinician, but one of the tests I often read about to test for cerebellar function at a primary physician level is you will ask the patient to reach out and touch something at arm's length, but the physician will put an obstacle in front of their hands at the last moment. And so you have to be able to, you can do it here, you can slap the person beside you on the back of the head or something. And of course, but once you've learned that movement, then that's really no longer cerebellum, it's that initial movement. And it degenerates with age, although the cerebellum is, for whatever reason, I don't know why, ages the most, of all the regions of the brain, the cerebellum ages most slowly. It's the youngest throughout your life. Nevertheless, what happens as you age, as you lose the ability to close focus with your eyes, as you lose dopaminergic cells in the substantia nigra, you also begin to experience something called cerebellar tremor. And that'll be when you, I don't know, you have something small sitting on a table in front of you, you reach down, everything's going fine, it's a happy day, good life. But as your hand gets close, it starts doing this. You retract, you're fine. There's no tremor. You reach down again, it starts. You don't know what I'm talking about as you age. That's a typical example of cerebellar tremor, not associated with any other tissue, not essential tremor that we saw earlier, not the problem of the basal nuclei. This is related to the ability of the cerebellum to correct these very fine movements. Probably don't want to. The cerebellum is important for. I think this is not well stated. Let me restate this. The cerebellum does not initiate movements. The cerebellum does not initiate movements, but once they've begun, it sees them to fruition. This is what I'm trying to say there.
What?
It allows them or facilitates their completion. Cerebellar patients, in fact, you will have no trouble finding on YouTube the hand walkers, individuals who are born without a cerebellum. They're really not capable of bipedal locomotion. In order to stand, they have to lean against something and walk up the wall or so on. But these are individuals born without a cerebellum. That's not really equivalent to a cerebellar patient, a patient who has lost the cerebellum to some trauma or something like that. I think you can already anticipate some of the issues these people are going to have. Basically, it's going to be rather severe dysfunction of motor capability. Cerebellar patients also exhibit hypotonia. This is a term we'll use throughout both courses. Hypotonia means a loss of normal muscle tone. What do we mean by muscle tone? I know the guys before the dates on Friday night do a few push-ups, pull-ups. What do you do that for?
Your muscles are ready for action.
Yeah. You know how to roll, that's right. I do the same thing before class every day. But yeah, by tonicity, by muscle tonicity, we mean a mild, persistent state of activation. And other tissues can exhibit tonicity too. Anytime we talk about a deficiency of physiological tone, I think George is exactly right. It's a deficiency of readiness. And so Down syndrome babies are hypotonic. They have exhibit hypotonia. They have flaccid musculature, and that can often be diagnostic of conditions. And so with cerebellar patients, because of a loss of physiological tone. Cerebellar patients also tend to exhibit ataxia. Ataxia is usually just a general term suggesting an abnormal gait, but it can also refer to upper body dysfunctions as well. Now, in your patho courses, you'll learn the complete lexicon of motor problems, everything from hemibolismus to apoptosis and writhing and so on, dystonia. But ataxia, generally, if it's cerebellar, it just has a very characteristic gait that you'll learn about. Oftentimes, depending upon the region of the cerebellum that's involved, the patients will exhibit an ability to balance themselves rather. We aren't quite sure of the pathways involved there, probably related to these pathways between the cerebellum and the motor cortex. And then this is a fun term. Anybody want to give this one a try?
Dyskinesia.
Excellent. Dyskiadochokinesia. Dyskiadochokinesia. And that is just a general term to refer to the progressive loss of ability to make rapid alternating movements, like playing bongos or something like that, or rotating your hand very rapidly. Cerebellar patients tend to lose this capability over time. This is just a little diagram of the relationship between the motor cortex and the cerebellum. Again, this is just illustrating in a graphical form the relationship between the fact that the motor cortex is the final common pathway, and as those signals are being sent down to the muscles from the primary motor cortex, the cerebellum is intercepting them, correcting them, intercepting them, and correcting them. Now, what information is it using to correct those motor signals? Sensory information from your eyes, from your fingers, so on. Again, imagine writing a computer program to do all of this. Anybody watch that robot competition recently? It was on all the news, because all the robots did for the most part was they would get to a door and just fall over. And so I'm not quite there yet. I think I can still take a DARPA robot at a door. But it's quite amusing. They just do not know how to handle the door. I'm getting there. I shouldn't laugh. The cerebellum, as I've indicated, has this, as we talked a little bit earlier about the arbor vitae, tree of life. The cerebellum is the little brain. It has its own little gyri and sulci, except in the cerebellum we call the gyri folia. Not terribly important, but the little convolutions are called folia. But what we're looking at is the three-layer organization, the three cellular. I'm not sure that's technically correct, but in any case, this is the white matter of the cerebellum. And so you can see the tree of life. That's what the arbor vitae refers to. And then peripheral to that, outside that, are going to be a couple layers of cells. We'll talk about that. You have a layer out here, you have a layer in here, and a layer here, and then here's that white matter. And the cells that are in here, we'll talk about this, send their signals back to what are called deep cerebellar nuclei. So all of these cells basically send just a few axons to these deep cerebellar nuclei. What do we call that organizational system? Yes, convergence. The cerebellum is extremely convergent. Millions of neurons to just a few axons. So here we're looking, and we can introduce some of the terminology used to describe histological regions of neural tissue in our discussion of the cerebellum. So again, just a few layers. You can see a couple of different pictures here showing the same thing. So this would be one of the folia we're looking at here. That would be the folia there. The outer layer, this layer out here, which is also this layer here, is usually called the molecular layer. And that's going to be true for a variety of neural tissues. The outer layer is usually called the molecular layer. The region in here, also this region down here, is usually called the granular layers because it has this granular appearance histologically. And those granules are cell bodies. It's actually neuronal cell bodies, not glial cells. So a lot of neurons in the granule layer, not so many up here. This is mostly just up here in the molecular layer, mostly just neurites communicating with one another. Now, if the question is, what type of neurites, let's talk about that, because the third layer is the layer in between the molecular layer and the granular layer, and it's right here. And what you'll notice in that layer are these large cell bodies. There's one there. Those are Purkinje cells. There are several different types of Purkinje cell in the body. These are Purkinje cells of the cerebellum, but we've seen the picture of these several times. So These are the beautiful cells that have the large cell body and then the beautiful tree radiating in all directions and then a single axon. Well, the radiation of dendrites is up here. So the Purkinje dendrites are out in the molecular layer. And then they send a single axon through the granular layer to the deep cerebellar nuclei. Purkinje cells, for reasons we don't need to get into these circuits because it's too complicated. But you should know that they are GABAergic cells. These are inhibitory cells. We'll talk a little bit more about inhibition and motor function as we get to the basal nuclei. But you should know that they're GABAergic. By the way, before we take a break, when we describe a neuron as being cholinergic, adrenergic, GABAergic, what are we actually describing? What are we referring to?
Receptors.
All right, that's what I was afraid. What the term, that adjective refers to the neurotransmitter that is released. All right, that's the neurotransmitter that is released. Make sure you understand that all of these cells that we call an adrenergic cell can have many types of receptors. A GABAergic cell can have many types of receptors. So I should have made this clear before. So when we describe the cell as being adrenergic or cholinergic, we're talking about the type of neurotransmitter that it releases. All right, let's take a break.